It's 8
Monica,
o'clock.
we are live now.
Good evening, everyone. I am Dr. Monica, medical advisor from Shield Healthcare. I welcome you all for today's webinar for Gujarat Zone OBGYN Societies and topic FGR Dilemmas. And I welcome Dr. Ridhi Bhatt. She's a senior resident at SVP Hospital, Ahmedabad, Fellowship in Fetal Medicine, Resolution Fetal Medicine Center, Hyderabad. I welcome you, ma'am, and I hand over this session to you.
Thank you, Dr. Monica. Good evening, everyone. It is my privilege to introduce Dr. Varsha Baste ma'am. Ma'am needs no introduction. She is the director of Baste Maternity Hospital and Pushpa Fertility Center. She was the chairperson of FOXI IAEC from 19 to 2022. She has received multiple awards and accolades from bodies around the globe, like Anandibai Joshi Award, Champions of FOXI Award. She has a vast experience in the field of obstetrics, gynecology, and IVF, spanning more than 30 years. Over to you, ma'am.
Yeah. Good evening and welcome you all. Sorry for the little delay because of the technical issue a little bit. I welcome you all, Dr. Atul Munshi sir, Dr. Kavita Bapat, Dr. Doshi sir. I cannot see him, but he must be here somewhere. This is the webinar. Specially, we have started for Gujarat Zone webinar. This is the third webinar that we are conducting, and at a time we are taking only one subject to discuss it thoroughly, and great take-home messages and great updates we get from the stalwarts who are really expert in that particular field. So I welcome Dr. Atul. Today's webinar is for FGR. We as a gynecologist obstetricians are really worried for such problem of FGR or preterm birth, and we only can tackle it very well to prevent it and to give better pregnancy, continuation of the pregnancy by anticipating it and by giving treatment and good antenatal care. We definitely can prevent this problem of FGR or preterm birth. So this topic is very essential nowadays, and it has got vast knowledge we need from fetal medicine person, and we have Dr. Chinmay Ratha and another Dr. Patel sir from our Gujarat only to talk about it and highlight how to prevent it. And Chinmay Ratha, you are I really like your all sessions because you give so many scattered take-home messages in your talks and panel discussions. So I start with our chief guest, Dr. Atul Munshi sir. Welcome, sir, for giving your time, and you are such a great personality. I really admire your humility, a pleasant person, so humble and down to earth, great leadership qualities. Dr. Atul Munshi, sir, is a consulting obstetrician gynecologist from Ahmedabad, director of Munshi Group of Hospitals, former professor, HOD of NHL Medical College, Ahmedabad, associate editor of journal.
Don't go through all.
Thank you, sir. Thank you for there are many publications to his credit, and he was senior vice president of FOXI 2007 and also president, and many credentials to his credits. So can we have little words of wisdom to be scattered all over in this webinar? Over to you, Dr. Atul Munshi, sir. Thank you so much for attending.
Good evening, everyone. Our hardworking Dr. Varsha is always in forefront of all academics. I'm thankful to her for involving me in this academic activity. I welcome my friend, multifaceted Dr. Praful Doshi. I don't see him, but he must be roundabout. An evergreen all-rounder Dr. Kavita Bapat to join me in this interesting yet little unexplored topic of fetal growth restriction. Fetus is a patient too that has been accepted now for a long time. This is gaining lots of interest in current obstetrics practice with fetal therapy and early diagnosis of any fetal problems. I'm sure Dr. Mayank, Dr. Chinmay, Dr. Riddhi, and all learned panelists will give us lots of insight in this hot topic, in this hot season. Wishing you all the best for this webinar, Dr. Varsha and Dr. Kavita for the future endeavors. Thank you very much.
Thank you, sir. Thank you so much for giving us the advice, and your pearls of wisdom is really will be remembered. And we admire your leadership qualities, and you are such a great personality in Foxy to look forward to you. Now we have our guest of honor, Dr. Praful Joshi, sir, but I cannot see him, but still I will read his CV because Dr. Mitsu Doshi and Dr. Praful Doshi are great friend of mine since long. We both started our ART clinics mainly at the same time in 2002. So we were really associated, taking help of each other. And I know how humble person he is, and he's really master in all subjects and really a great orator. So we are really happy to have you, Dr. Praful Doshi, sir, but maybe he is also on vacation, so it might not be able for him to get connected, maybe because he was abroad somewhere on vacations. Our next guest of honor is none other Dr. Kavita Bapat, madam. What should I say about this great friend of mine, and such a glorious journey she has, a lady, and she is a woman of a substance, a courageous, bold, beautiful, great orator, great qualities, 7 gold medal holder. I will not read her CV because it is too big, but I will only say that she is a woman of substance who stands for a justice, and really great, courageous woman. I really admire her qualities and what not she has done. 1 minute, 7 minute webinars, pearls of wisdom, take home, learn simply. One day surgeon, vaginal surgeon, who is only one surgeon who is a female doing distinctive work, surgeries. I've seen so much of crowd around her hospital. In OT, she does 3-4 surgeries daily. Quickly, even educating the students about how to do their surgeries and all. And she is really a great leader from Madhya Pradesh. So I welcome you, Dr. Kavita Bapat, and please give us some advice. Please give some address to us this webinar. Thank you.
Thank you so much, Varsha.
Can't hear you, madam.
Be my friend all my life. And you are my friend. That's my really the privilege. I'm telling you.
Please, ma'am, talk loudly.
Am I audible now? Hello?
Yes, you are audible, but talk little loudly.
Yes,
Oh
yes, now.
Munshi sir, I'm audible, no?
Yes, please.
Yes,
Absolutely,
yes,
yes.
Yeah, sorry for that. In all regards to Dr. Atul Munshi sir and Dr. Joshi today, I've seen how the leadership works in Foxy. I've seen last 20 years how Atul Munshi works. So, sir, thank you so much, Varsha, for giving me the platform today to sit next to him as a guest of honor. It's all thank you so much today. And today you are having such a great subject like the fetal growth retardation. I tell you, so many things are there. There is no this thing registry for this. So Chinmay, you can start registry on fetal growth retardation in our country, because if not for the stillbirth, not for the fetal growth registration, still we need a lot of work to be done, because accurate diagnosis is very important. Identifying the underlying causes are another important point. And the third most point about it is how to monitor and how to manage and how to give the results. A fetal medicine person like Chinmay and who is going to speak another is I think. So I am sure that this webinar is going to be a very good, those who will listen today, because this is really a good and great topic, and definitely Chinmay do some hard work on it as a committee chair on this subject and start a registry on this. So congratulations, Varsha, once again, that you have chosen this topic and allow me to sit close to the Dr. Atul Munshi, sir. So thank you so much. Be my friend always. And thank you so much.
Thank you for gracing the occasion, Dr. Kavita Bapat. You are so busy, but you could make time for us and grace and increase the standard of this webinar. Thank you, Dr. Atul Munshi, sir, Dr. Kavita Bapat, and Dr. Doshi, sir. He must be finding it difficult to log in, but he had assured me that he will log in. Over to you, Dr. Bhatt, to
Yes,
proceed with the.
Now I'm going to introduce two chairpersons of our first session, Dr. Darshan Shah. He is AOGS Managing Committee member. currently working as a consultant gynecologist at Raj Women's Hospital. He is having special interest in laparoscopy and high-risk obstetrics. Over to you, Dr. Darshan. And our second chairperson is Dr. Akash. Currently, he is working as a senior resident at LG Hospital. Areas of interest is high-risk obstetrics and fetal medicine.
Good evening, everyone. I'm Dr. Darshan.
Thank you so much, Dr. Aditya.
And today's topic is prediction of preterm labor, which is going to be taken by Dr. Varsha ma'am. So I request Dr. Varsha ma'am to continue with her talk.
Thank you, Dr. Darshan Shah, for your kind words. I will just share my presentation. Give me some time, just a minute. Is it seen on the screen?
Yes, madam, it is seen.
Yes,
It is
ma'am.
seen. Yes.
Okay. So my topic today is the prevention and management of preterm labor, new consciousness in preterm labor. It is very, very important topic because we as an obstetrician can anticipate it and prevent it and treat it. And so the fetal mortality and morbidity can be reduced by timely intervening and giving the proper antenatal care to each and every mother. So maybe this is very sad to see such a picture arrive too soon. The burden of the problem is every year an estimated 15 million babies are born preterm before 37 completed gestation. And the number is rising. And the survival, the 3/4 of these deaths could be prevented by us with cost-effective interventions. Survivor face lifetime of disability in the form of learning disability, myopia to hoi jata every baby, visual and hearing problems, and across 184 countries, the rate of preterm birth ranges from 5 to 18% of the babies born. Unfortunately, India is at the top of it. WHO defines that preterm is defined as the onset of labor after gestation of viability, and babies born alive before 37 weeks of gestation are completed. The period of viability, the extremes variable differ according to the state, city, and country. So the WHO classification of preterm labor is extreme preterm when it is less than 28 weeks, early preterm 28 or less than 32 weeks, and late preterm is the baby or the pregnancies of 32 to less than 37 weeks. There are multifactorial interactions which can lead to this preterm birth. Cervical problem is major chunk of the causes. Then uterine stretch, uterine contractions, abruptio placentae, abnormal implantation because of premature decidual activation. This metabolic syndrome medically indicated like diabetes and other NCDs. Hormonal progesterone withdrawal, immunological inflammation, genetic infections can cause premature rupture of membrane, and so preterm birth can occur. So what are the WHO recommendations on intervention to improve preterm birth outcomes? Steroid injection before birth, antibiotic to be given in PPROM before onset of labor, max self to prevent further neurological impairment, to avoid cerebral palsy or motor neuron problems, and intervention of the newborn baby with NICU and thermal care. So there are dilemmas with definition, starts from definition, diagnosis, can it be prevented, can it be treated, can it be predicted, what are the preventive management, what is the definitive management, the dialogue between the obstetrician, neonatologist is very, very important, where to transport, how to transport in utero, how to do the delivery delivery, whether it should be vaginal or C-section, and what sort of whether to apply forceps or not. So there are very dilemmas. Criteria for preterm labor is documented uterine contractions. It is 1 in 10 minutes. Rupture fetal membranes. Documented cervical change like less than 1 centimeter, or cervical dilatation more than 2 centimeters. So what will be the management? It is preventive. It can be predictive, preventive, and definitive. Let us see the prediction of the preterm birth. Either we can do it by screening, risk factor assessment, cervical measurement, and biochemical markers. The risk factors are non-modifiable and modifiable. So non-modifiable risk factors are prior history of preterm birth, age less than 18 years or more than 40 years, extremes of BMI less than 19 or more than 30, low socioeconomic status, unhealthy hygiene, cervical injury, uterine anomaly, or distended uterus due to multiple pregnancies, or fetal congenital anomalies. What are the modifiable risk factors? Poor nutrition, medical disease like GDM, diabetes, thyroid, SLE, asthma, anemia, infections, substance abuse, tobacco or alcohol, asymptomatic bacteriuria, strenuous work, assisted reproductive technology. Definitely a major group of the patients can suffer PTB who undergo ART, IUGR and PIH. Cervical measurement is up to very utmost important. When a short cervical length by TVS 15, 16 to 24 weeks is reasonably accurate predictor of preterm birth. The threshold of cervical length at 24 weeks is defined as 25 mm with 37.3% sensitivity and 92% of specificity. The knowledge of cervical length has reduced the risk of PTB before 37 weeks. With the cervical length less than 15 mm, it is the optimum cutoff with 81% specificity and 83% accuracy for predicting true preterm birth. So cervical elastography is also known. So this is the picture we see on ultrasound. Short cervix, there might be coning or bulging of the membranes, and we can diagnose it as a cervical incompetency. Then what are the biochemical markers? Cervicovaginal fluid. The fetal fibrinectin, that is glycoprotein produced by aminocytes and cytotrophoblast, are seen in maternal in this cervical vaginal fluid before 22 weeks of gestation. But if it is present between 24 to 34 weeks of gestation, it indicates the risk for preterm birth. Then placental alpha macroglobulin has a greatest utility for predicting the preterm birth by 95% specificity. Insulin-like growth factor binding protein was a reliable bedside test to predict the preterm birth. So there are many research is going on, metabolomics, proteomics to predict the preterm birth. In amniotic fluid glucose level, matrix metalloproteinase, vascular endothelial growth factor, VEGF, placental growth factor, PGF, different kind of interleukin 1B or up to 8. Then other research is going on to predict preterm birth. Biochemical markers like maternal serum marker, maternal salivary estradiol measured in 25 to 34 weeks has 82% specificity that whether she will undergo PTB or not. Serum progesterone induced blocking factor is also predictive whether she will undergo PTB 5 days prior to preterm birth. And the different proteomics and other molecular research is ongoing. So in conclusion of predicting, it is really a challenge of modern obstetrics, but fetal fibrinectin or transvaginal sonography with cervical length is most predicting of the preterm birth, and we can anticipate it beforehand, and we can give the patient treatment accordingly. The screening for bacterial vaginosis is also very, very important because the infection is closely related to rupture of PPROM, which accounts for 1/3 of preterm birth. So we have to give prior antibiotic to prevent preterm birth, but it should not be prophylactic, but in some cases we can definitely give it. So preventive measures for preterm birth is progesterone and cervical cerclage. Progesterone is a magical pill. It maintains uterine quiescence by acting at all sides, like at placenta. It regulates timing of labor by controlling sex hormone in amniotic fluid. It limits prostaglandin production at fetal membrane. It blocks pro-inflammatory cytokine-induced apoptosis, prevent PPROing at myometrium and cervix. It suppresses the inflammatory response and quiescens the uterus. So progesterone is magic pill. Natural progesterone offers complementary anti-inflammatory, immunomodulatory, and uterine quiescent action by inhibiting oxytocin activation, prostaglandin production, inhibiting gas junctions, inhibiting cervical ripening by downregulating production of cytokines, inhibiting connexin 43 and gap junction protein. So what are the options of giving this progesterone? Natural progesterone like soybeans, maximum, yam roots are also available, but the half-life is increased with metabolite like allopurinol, and micronization decreases the particle size and absorption is increased. So we are definitely using micronized progesterone. So what is the route of administration? Injectable 17-alpha-hydroxyprogesterone is given to 50 milligram intramuscularly weekly till 36 weeks, or we can give vaginal tablet 200 to 400 milligram or vaginal gel 8% every night. We can insert it, though little costly, but it gives sustained release of this progesterone. Sometimes the patient is from remote place, so this micronized slow release progesterone, which is given orally, though we do not like, but the patient, if they are from remote place, they cannot afford vaginal progesterone, they cannot take the injection, then you can give the oral slow release tablet form, which may have side effect like sedation or dizziness. So vaginal progesterone is the best because it reduces the risk of spontaneous preterm birth by 20 less than if it is less than 34 weeks. It reduces the spontaneous preterm birth by 37%, and neonatal morbidity and mortality is reduced by 41%. Now, surplus teaching time. It is indicated in for the end of the first trimester. Prophylactic cerclage, it is debatable, but it depends on the patient's history and personalized decision. Rescue cerclage, one must give, but if there are bulging membrane or very short cervix, but there should be no sign of labor or contractions or infection or bleeding. So rescue cerclage, does the bed rest is needed? It is not needed, but she should do light work. So what are the recommendations for rescue cerclage? It should be done for 20 weeks, but it can be done after 20 weeks also. It should be individualized. And there should not be infection, vaginal bleeding, or uterine contraction. And the neonatologist, the unit with neonatologist facility should be there, and counseling is also very important. So one NICE guideline tells us that prophylactic vaginal progesterone or prophylactic cervical cerclage should be given to a patient who has previous history of preterm birth, or the cervical length is very less than 25 mm or 25 mm at 16 to 24 weeks. Go for prophylactic vaginal progesterone or prophylactic vaginal cerclage, or otherwise you can customize it. So how will you manage the preterm birth? It is overdiagnosed, it is misdiagnosed, there are unnecessary interventions, prolonged bed rest, hospital admissions, high cost of saving neonate in ICU, long-term vigilance for perinatal problems afterwards also are problematic. So the information for the patient, if it is threatened, suspected, or established, we have to give both mother and father oral and written information. Counseling is very, very important, and she should know what are the signs and symptoms of preterm labor. And if it is, if she has established or she's a planned preterm birth, then tour to neonatal unit, dialogue with the neonatologist or pediatrician, and the counseling and explanation is very, very important to increase her confidence and her family confidence also. Now, diagnosing the preterm rupture of membrane, we have to do speculum examination. The pooling of amniotic fluid is observed, and if the biomarkers are also there. Sonography is the best to see the amniotic fluid, the deep vertical pocket, how much is there, if there is real leak or no leak. and then we can accordingly give the treatment. And also the gestational age, medical and pregnancy history, if it is singleton or prenatal pregnancy. If it is a PPROM, we have to start with antibiotic like erythromycin 250 milligram 4 times a day, or any antibiotic of your choice, but don't give co-amoxiclav. And you can definitely monitor the patient with erythromycin and then take the decision whether to terminate the pregnancy or not. Now, tocolysis. Very, very important. When the gestational age is 24 and 34 weeks, tocolysis, the objective of using tocolysis is to delay preterm birth, to allow antenatal care, to improve neonatal outcome, to optimize the fetal lung maturation, to arrange for maternal transfer in utero to the tertiary level, to administer antibiotic to neonatal, especially if it is problematic pregnancy, administer magnesium sulfate for neuroprotection before anticipated delivery, and the duration should be as short time as possible within 48 hours. So what are the indications for tocolysis? Gestational age 24 weeks to 34 weeks. Spontaneous premature contraction, that is painful, palpable contractions lasting longer than 30 seconds, more than 3 in 30 minutes. Functional cervical length less than 25 mm on transvaginal sonography or cervical dilatation. What are the contraindications for tocolysis? The absolute contraindications are chorioamnionitis, APH, advanced cervical dilatation, PIH, eclampsia, chronic renal failure problems, IUD, gestational age less than 24 or more than 34 weeks, and maternal comorbidities. Relative contraindications are PPROM, mild APH, IUGR, and twins. Ideal agent. This is very, very important. Which one, the tocolytic, we should use? Now the uterus-specific atosiban is available. New uterus-specific atosiban, that is the new consciousness. How does it work? How does it act? It is oxytocin receptor antagonist, effective, significantly increasing, prolonging pregnancy, low incidence of maternal and fetal side effects, licensed to use as tocolytic, intravenous use. It is expensive, but the cost of baby's care in NICU is far, far more than the actual drug cost. So definitely it is. It has been used. Many trials are taken in Mumbai, Sayana, and Nair Hospital also, and they have given fantastic results with atosiban, which is uterus-specific relaxant to prevent or to prolong the pregnancy. It is given in 3 stages in 48 hours. Over 1 minute IV, 6.75 milligram in 0.9 ml. IV infusion 24 ml for 1 hour up to 3 per hour up to 3 hours, like 300 microgram per minute. If the contractions are still there, then IV infusion 8 ml per hour up to 45 hours, that is 100 microgram per minute. So this is the protocol. And atosiban, each 5 ml solution contains 7.5 milligram as acetate. Each ml has 7.5 milligram per ml. I would like to tell everybody that atosiban is a drug of choice now to prevent, to prolong pregnancy, and to rescue the better fetal well-being. Now, other non-uterus-specific are substance class like calcium antagonists, MAC-SULF, inhibitors of prostaglandin synthesis, nitric oxide donors, and beta-mimetics. Active substance, nifedipine is drug of choice. We all are using it. But endometriosis, for some cases, we use nitroglycerin, isozoprin, terbutaline is not available, litrodin, they have side effects. Nifedipine safest. It is a calcium channel blocker which reduces intracellular calcium by blocking influx of calcium and thus resulting in myometrial relaxation. Ease of administration, oral, we do not give it sublingually. Everybody knows that. Low cost, better neonatal outcome, and fewer maternal side effects. Disadvantage is that it should not be used with MAC-SULF. Recommended dose is initial dose 20 milligram followed by 3 further doses of 20 milligram every 30 minutes if the contractions are persistent, and maintenance is 20 to 40 milligram orally 4 hourly for 48 hours, or otherwise also we can give 20 to 40 milligram so slow release for maintenance to avoid the contractions. The side effects, we all know 25% of the patient do have hypotension, palpitation, dizziness, headache, flushing, but it should not be used with Maxelf. Other beta antagonists, terbutaline, ditodin, we will not discuss because they are not used and they have side effects. Indomethacin, limited data is used. So nifedipine and atosiban are the drug of choice due to their uterus specificity and better safety profiles. Now, unbeatable antenatal corticosteroid and Maxelf. Antenatal corticosteroid and Maxelf have revolutionized the management and outcome of preterm birth. It has the corticosteroid reduce the RDS, improve the circulatory stability, resulting in lower rates of intraventricular hemorrhages, which is the major reason for neonatal mortality and morbidity. They accelerate the maturity of type 1 and type 2 pneumocytes, which increases the surfactant production, improves alveolar gas exchange, and mechanical functioning of the lungs is improved. Maxelf acts as a neuroprotective agent against cerebral palsy and other types of severe motor dysfunction. So the indication for antenatal corticosteroid is women with 22 weeks to 34 weeks of gestation who are at increased risk for preterm birth with the next one within the next 1 to 7 days. The choice of drug is betamethasone. Many times it is not available, so we can use dexamethasone. Betamethasone 2 doses, 20 milligram intramuscular, 24 hours apart, or dexamethasone 4 doses, 6 milligram intramuscular, 12 hours apart. So there are queries, multiple doses, how many doses we should give. Even if we give single dose, that is okay. If it is a twin, should we increase the dose? No need of increasing the dose. Even single dose, even if it is given, it is okay. Maxelf as a neuroprotecting, robust data is available. It is really good to use against cerebral palsy and severe motor dysfunction. How is the mechanism of action of Maxelf? It stabilizes cerebral circulation by stabilizing blood pressure, stabilizing the neuronal membranes and blockage of excitatory neurotransmitters like glutamate, antioxidant effect against oxidative injury, and anti-inflammatory effect to protect against inflammatory injury. Now there are multiple trials. We all know the BEAM trial and all. So we know the doses also 4 milligram loading dose of Maxelf followed by 1 gram per hour for maximum 24 hours. Only contraindication is impaired renal failure or myocardial compromise. It should be used in pregnancy less than 32 weeks. Now, how will you proceed for labor management? Intrapartum management, very, very important for fetal surveillance with CTG is must. Admission should be done. Maternal transfer in utero is advised. Antibiotics to start, and how will be the route of delivery, that is personalized patient to patient. We can go for normal delivery also, but no role of vacuum and forceps. Caesarean section, we can go, is beneficial if it is non-vertex presentation. So it is an individualized decision. Episiotomy is indicated, cord clamping little delayed is advised. Neonatology should be present for all deliveries, readiness for resuscitation should be done, and also transport for NICU should be available. Support to the mother, reassurance, tender loving care, active involvement of mother, husband for the childbirth, and for post-delivery bonding and care is very important. So the lessons learned are screening for high risk preterm. There should not be any careless. Madam, मेरा पेट दर्द होता है. अरे तू गोली खा के सो जा. No, nothing like it, because we have to take it very seriously. Cervical length between 16 weeks to 24 weeks, a gold standard, and don't disregard this finding if the risk factors are there. Don't ignore symptoms of abdominal pain. Cervical changes, PPRO, and uterine activity should be monitored. Role of antenatal corticosteroid, Maxelf, short-term procolysis are very, very important to delay the pregnancy, to delay the delivery, preterm birth, and prolong the pregnancy. Have a policy of in utero transfer and close dialogue with the neonatologist, who is running the tertiary care nursery, and close follow-up of the baby, mother, and also the next pregnancy is very, very important. Thank you. Thank you for your patient hearing, dear friends. I am going for the post of Foxy Vice President West Zone. Do मेरा चेहरा देखो और शिक्का मारो. Thank you.
Thank you, Dr. Varsha. Enlightening presentation
I will
on the right prediction of preterm labor. But this presentation, and thank you for a very valuable experience. Thank you so much,
Thank
ma'am.
you. Thank you for your patient hearing.
Yes, yes. Thank you, ma'am.
Ma'am, Dr. Doshi sir has joined.
Hello, Dr. Prabhul Doshi sir. Namaste. Welcome to this webinar. We were waiting for you. You are the guest of honor, but you could make it to join. Thank you so much for joining, sir.
Thank
Can
you,
you give
Varsha.
some address?
I heard your lecture and it was very comprehensive. You gave a complete picture of preterm labor, its diagnosis, prevention, prophylaxis, everything. Excellent.
Thank you so much for gracing the
Thank you
occasion,
for
sir.
inviting.
You are so busy, but you could manage to join. Thank you so much. Thank you. Regards to Dr. Mitsu Doshi, madam, also.
Thank you.
Over to you, Doctor. But
Yes, yes, ma'am. Now I'm going to introduce chairpersons of our second session, Dr. Aniket Tripathi and Dr. Deepal. Dr. Aniket Tripathi is currently working as a consultant gynecologist at Chaya Women's Hospital, and he has pursued his laparoscopic training from World Laparoscopy Hospital, Gurgaon. And Dr. Deepal, currently she is an assistant professor in Pramukh Swami Medical College, Karamsar. Over to you, Dr. Deepal.
Thank you, Dr. Riddhi ma'am. It's an absolute honor to introduce Dr. Mayank sir. Mayank sir is a very famous name in fetal medicine. He is currently giving services at Mayflower Women Hospital, and he has trained and awarded from many reputed societies. He has a special interest in twins, fetal growth disorders, first trimester fetal disorders, fetal echos. He also likes to teach and has recognized basic advanced training for the same. I would like to welcome Dr. Mayank sir and share his wisdom. Over to you, sir.
welcome, Dr. Mayank sir.
Thank you, Dr. Deepal, for those kind words. Let me share my screen. I think I am audible.
Yes, yes, you are.
My screen is seen there.
Yes, sir. Yes, Dr. Mayank. Dr. Mayank, you are not audible. Are you there, Dr. Mayank? You can see the screen.
You can make it full screen and then you can talk, Dr. Mayank.
I think sir has some net issue, ma'am.
Sahitya Priya, can you consult him and talk to him?
Okay, ma'am.
Please call him and ask if a problem is there.
I
Is
think
the net
before
issue
we
is there
start
or
that,
what?
before we start the discussion and the internet connections are getting sorted out, the chairpersons can give their little inputs. What do they think about the fetal risks in fetal growth restriction? Because we are, fetal growth restriction is a fetal problem, but we are particularly talking about the dilemmas, about the risks. So the chairpersons can give their input so that Dr. Mayank can then address those issues particularly.
What do you,
Thank you, ma'am.
chairpersons?
Thank you, ma'am. I would like to say that early diagnosis of fetal growth restriction will be beneficial to mother as well as the fetus. There is chances of intracranial hemorrhage, intraventricular hemorrhage, necrotizing enterocolitis and everything. So if we diagnose it early,
And
so
as
we
Kavita
can
ma'am
save
was
the
telling us, our
penalty.
guest of honor, our guest of honor, Dr. Kavita Bapat, was telling us that we should make a fetal growth restriction registry. Now, that would be
Yes,
a very
ma'am.
good thing to have that. but we have many practical problems on that count because the number of deliveries in this country is huge. I mean, we are the largest population as of now, and the number of deliveries we contribute every year is huge. So amalgamating everything together would be very difficult. And the bigger problem is that most of the FGR goes undiagnosed. So the FGR that we diagnose very clearly is the one which is also small for gestational age. But there's a lot of FGR that is not small for dates. So that is why sometimes. So Riddhi, do you have any inputs to give in terms of your experience with FGR that you've started now working as a fetal medicine doctor? Or Riddhi is busy organizing the...
No, ma'am.
Riddhi, unmute yourself.
Yes, ma'am.
Yeah,
ma'am,
how do you think? Is it easy to pick up fetal growth restriction, or what is your clinical experience with fetal growth restriction?
Yes, ma'am. With the help of Doppler, it is very like we can diagnose FGR in early onset as well as late onset.
Mayank Chaudhary, are you there? Ready with your presentation? You please unmute yourself, Dr. Mayank.
We also have Viral Pandya here. And Viral, would you want to give us some inputs? Parth is here.
Yeah. Hi, good evening.
Dr. Mayank, we are doing this just in the interim period till you get all set. So when you are set, you please let us know. Yeah, Dr. Viral, please go on.
Yeah. So, of course, I still believe diagnosis of FGR is a challenge. There are a lot of gray areas between FGR, SGA, constitutionally small, and I agree a registry might be helpful, but getting everybody on board to follow the same criteria, the same rules, is going to be a massive challenge considering the span of our country and the different philosophies that are being followed. So we have the tools, we have the growth charts, there is awareness about growth charts, there is awareness about Doppler, we can plot and diagnose, but it's still a challenge, yes. Picking up FGR correctly is a challenge.
So you think that we are all getting together this evening and discussing FGR dilemmas, it makes sense, isn't it?
Of course it does.
Because everybody thinks every time you people discuss FGR, but every time we discuss, we not only reiterate some of our problems, and that makes a kind of reassurance that everyone's having the same problems, and also that you know what's changing.
So FGR is not that as glamorous as the other abnormalities, so it somehow flows under the radar. And
nothing is glamorous in fetal medicine. But has Dr. Mayank got on board finally?
Not yet, ma'am.
So what's the scene?
Should we start with the panel discussion otherwise?
No, let's just hear from people who are working there. So Dr. Viral,
Yes,
what is the scene in Gujarat? I mean, do you think it's kind of something that you face every day, or you have to again explain to everybody why this is FGR, why a Doppler is needed?
No, so that thankfully we have that much awareness in our board of obstetricians that they do understand the importance of Doppler and Doppler changes, and that makes life a little easier for us as fetal physicians. But there are certain times when we don't really have a proper scan done earlier in order for us to pick up whether this was a growth pattern which was at a lower center from the beginning, or is it something that has started happening recently and it's actually a growth restriction pattern. So that is the challenge that we routinely face in daily practice here.
Since this is a very Gujarat zone webinar, before we start our true panel on the dilemmas, it will be good to get a reality check. Parth?
Yes, madam. Good afternoon.
Dr. Ami? Parth, you're there? Good afternoon. Afternoon, where are you?
Good evening,
काम
ma'am.
पे अभी तक But this
Good evening,
this is
ma'am.
a very common problem with fetal medicine doctors, because very often we get into the clinic and then it's all tube lights and shadows. So we don't even know what hour of the day it is most of the time.
Dr. Mayank Chaudhary,
Yes.
could you
Yes,
connect?
yes, madam.
Yeah. Then proceed, please, with your talk. Share.
The moment I am sharing my screen, something is
Yes,
happening.
yes.
So
We can see the slides.
Sir, no need to make it full screen, sir. Continue with this, sir. I think there was some problem. Yes, sir.
okay, I think now it is seen. I am
Yes.
very much
Yes, we can see.
sorry for a technical problem. And today's topic is fetal risk in FGR. And my main message is that with the use of umbilical Doppler and serial graph and various protocol, which next speaker is going to narrate in detail, we will able to identify this fetus as at risk, and we will able to make a timely delivery to this fetus. I am very much thankful to Dr. Atul Munshi sir, our mentor, my well-wisher, Dr. Praful Doshi sir, and Dr. Kavita Bapat madam, motivator of all, and the key organizer of Dr. Varsha Baste. And my main message is growth curve is equal to straight solution. If you follow the growth curve and various protocol, that management of at-risk fetus will be very easy. Regards from Mayflower Hospital.
Sorry to interrupt, sir. Your slides are not visible properly, sir.
Half is seen, or
They're
what
coming
is...
and going.
Yeah, it's blinking, sir. So I request you to please share the slides again, sir.
Okay.
Yeah,
I should
this
stop.
mode is fine, sir. Normal mode, please keep it in normal mode, sir, so that there won't be any issue. Yeah. Yes, sir.
Okay. Regards from Mayflower Hospital and my team. We all know life is full of risk, and this risk start from womb. And we all are in risky business of gynecology. And biggest fear of FGR when FGR is not detected. I will start my talk with this video.
Can't see the video. Yes.
Now?
Yes, we can.
So delegate who are attending this talk may be having such type of expectation from us, but that is not true, and such type of expectation from Doppler and science. But please remember, Doppler is not a vaccine and will not able to define a route of delivery, and normal Doppler is not equal to normal outcome always. Okay, I will start my talk with this case. This is a 12 weeks, 2 days detail of second gravida patient with previous male child, 6-year-old well, and maternal age is 27 year. In first trimester scan, mean uterine PI was more than 95th centile, and we offer a screening, and she was a screen positive for trisomy 21. And if we read in between the report, you can see that Papa mom was quite low, and we counseled the patient, and we did a amniocentesis. Sorry, CVS was done, and karyotype was normal. In karyotype, there was one additional information, 9QH inversion, that is quite a normal polymorphism. But at the end of genetics wrote that there is chance of 1 to 2% case, there is chance of fetal dysmorphism. And at 23 weeks, when we scan the baby, this was the face of baby. You can see here the long philtrum, upturned nose, and depressed nasal bridge. And we were quite in dilemma that what to counsel the patient with this normal karyotype report. We call patient for anomaly scan at 23 weeks. You can see here the AC and FL is falling well below third centile. You can see here in this graph, AC is less than third centile, weight is less than third centile, and fetal long bone was also on a lower centile. And in first trimester, uterine artery PI was on a higher side, but now we can see which has become normal after the giving a ecosprin. We call patient after 3 weeks because we were in dilemma that this is going towards the skeletal dysplasia or this is early FGR or what is that. And FL by foot length ratio was normal. And these are the value, but it is slightly cumbersome to understand the value. But when you go to the graph, the things become easy. And here we have previous information also, and we can compare that in a serial graph that interval growth of AC is fine, FL is not falling on right side too much, and fetal weight is interval growth is okay. And now again you can see the uterine artery PI started increasing, umbilical artery PI is on higher side of normal. So at this moment, this is tibia, this is ulnar information, and at this moment we at least ruled out that the baby is small, and it is this long bone biometry is not suggestive of fetal skeletal dysplasia. We call patient after 1 week at 28 week, and you can see here the ACFL fall in lower centile, and umbilical artery Doppler has become abnormal now. It is more than 95th centile. This is umbilical artery Doppler. And here you can see the AC serial graph going fine. It is on quite lower centile, but interval growth is fine. And this is a weight. And if we define this as a Gratakos protocol, this is falling in a stage 1. We call this patient after 1 week. And at 29 weeks, 1 day, the rest of the finding was almost same. The growth was on lower centile, umbilical PI was on a higher centile. This is umbilical artery PI with AC and EFW less than third centile with abnormal umbilical artery Doppler. Still, this fall in stage 1. We call this patient after 1 week, and this is a serial growth of at 30 weeks, 1 day. Rest of the biometry following same trend. This is a serial growth graph, AC, umbilical artery Doppler, MCA, and here there is one interesting observation in MCA peak systolic velocity. You can see from normal centile, it is rising. So by this time, there was a lot of tachycardia to us, to parent, and we call this patient in a close follow-up. And just after 4 days, we come with a finding of absent reverse end diastolic flow. And there was a decreased fetal movement also. AC, weight, and umbilical PI was absent reverse end diastolic flow, which is well above the higher graph, so it is not shown here. And MCA PS, you can see it is still rising and rising high. So now it was stage 3, and decision for delivery was taken because the risk of stillbirth was very high as compared to the risk of prematurity, and that is a guideline. This is the outcome. LSCS 900 gram weight 29 at 30 weeks, and baby was in NICU for 20 days, and now baby has crossed 10th birthday. So apart from that, there was one important observation in this case, that MCA PSV last two reading was quite high. And this is a paper from Gincario Mari himself, that when MCA-PS is more than 1.5 mom, it is not always a fetal anemia. And in conclusion, he wrote that a high MCA-PSV predict perinatal mortality better than does a low MCA-PI. You can see in this graph that this black dot, black circle are perinatal mortality, and this is a MCA-PI. And on the right side, you can see MCA peak systolic velocity. These black dots are perinatal mortality. And you can see this in this specific situation, MCA PSV is performing better as compared to MCA PI. So learning point in this case was we did a screening and we were able to identify a high risk fetus. And with the help of serial monitoring, serial graph and surveillance, we drag this pregnancy near the viability, and at proper time judicious decision was taken, and it was a teamwork. The outcome was very good, and MCA PSV more than 1.5 mom is not anemia always, and 3D 4D can create artifact, so be cautious. Short small FL as a cause of aneuploidy is not so common as we think. We know that there are mainly two risks in this fetal growth restricted baby. One is a stillbirth and prematurity. And prematurity due to maternal reason, like in preeclampsia and all those cases, we have to deliver early. And when there is a judicious decision at that time also, we will take a decision, and there is a compulsion to deliver prematurely. But when the FGR is not diagnosed properly, or there is a mismanagement, and that is a big group and iatrogenic prematurity, and we should avoid that. Apart from the risk of prematurity, there are other risks, sequel like necrotizing enterocolitis, birth asphyxia in NICU, and neurological risk in a FGR baby when it is delivered prematurely. Any ultimate goal of any pregnancy is to reduce stillbirth and reduce handicap. And you can see in this data, this is a large scale data of stillbirth. And you can see here the distribution. This open circle shows the antepartum SB. This is less than 32 weeks. This group is less than 32 weeks. On right side upper, you can see this group is more than 32 weeks. So there is one pattern in this group. You can see here in less than 32 weeks, the fetal weight is on lower centile. So it is slightly easy to identify. But when it reaches near the term, you can see majority of this stillbirth are AGA baby, or in some case, it is a large for gestational age. So there was a need to define FGR in a new way, and to reduce this, this new definition came, and this is called a reverse phenotyping. Not only growth restricted baby, but this new definition can identify the baby at risk of high perinatal mortality and high risk for SB. This will be taken in detail by next speaker, and this is a Kratakos classification. Again, this will be taken by our next speaker. So reduction of fetal risk in FGR is very much important, because improved antenatal detection of FGR is crucial to have a positive impact in stillbirth prevention. And in up to 1/3 of pregnancy, FGR may be missed, and it is incorrectly diagnosed about 50% of time. Without the correct diagnosis of FGR, antenatal surveillance may not be performed. timely delivery of the fetus at risk due to unfavorable intrauterine environment will not happen. So the main thing is to identify the fetus which is FGR, which is at risk. There is no treatment has been demonstrated to be benefited in FGR. The only thing is surveillance of fetal well-being and timely delivery. So that our next speaker is going to take. Thank you very much. And sorry for those technical glitches.
No, that was good. I mean, your technical errors helped us to interact, and माहौल हमने गरम किया आपके लिए. Because we wanted your talk to happen first so that we are well in line for the next session. Thank you so much, Dr. Mayan. So if the chairpersons have to say something, please go on.
Yes, ma'am. I would like to thank Mayank sir. It will help us to it will help us in our day-to-day practice for timely delivery, when to intervene, what to look for, and everything. So I really like the lecture, and I think it will be great help to the listeners also.
Yes, absolutely, absolutely. And when I requested him to talk according to the color Doppler indices and all, that is what you have really justified, Dr. Mayank Chaudhary. Thank you so much for giving good, subtle take-home messages, how to do it and when to predict and how. It is not a magic. That is what you have, in the beginning only you have declared about color Dopplers. Thank you so much for your really well-read, well-updated presentation. Over to you, Dr. Riddhi. Now I will only introduce the next important panel discussion, none other than conducted by moderator Dr. Chinmay Ratha and Dr. Riddhi Bhatt. Riddhi Bhatt is the student of Dr. Chinmay Ratha, so I thought that combination will be the best because each one knows each other. Dr. Chinmay Ratha, what should I say about this pleasant personality? I am really, she's such an adorable person. She's the chairperson of National Perinatology Committee, FOXY, and President Secretary Society of Fetal Medicine, Telangana chapter. She is a director, lead consultant of Fetal Medicine Resolution Fetal Care Center Research Institute. Okay, with this short introduction, because she has lots of credentials and she is the most wanted person for fetal medicine to highlight and give updates to many take-home messages, new ideas, and so we are really eager to hear you, Dr. Chinmay Ratha. Over to you. Please start the panel discussion. Thank you for gracing the occasion and increasing the standard of this webinar. Riddhi, I welcome you.
Thank you so much, madam. And it's really nice of you to include Riddhi as a co-moderator with me, because these are the next generation of fetal medicine specialists. And just like we have to care for the fetuses that we scan, we also have to care for these fetuses who are now fetuses in fetal medicine, who will then become extremely useful consultants and clinicians in the future.
Buddy fetal medicine experts. Good.
So Riddhi came and spent time with us in Hyderabad doing her certification course of the ICOG, and she topped her batch in the last examination. Wow. She is going to receive her prize in the AICOG next year. So she is extremely talented and very good with technical issues. So, so I look forward to hearing a lot about her in future. And we also have a very eminent panel of experts in our discussion panel today. We have Dr. Ranjit Chaudhary, who's been the ex-president of BOGS, and I can see that he also has a postgraduate qualification in medico-legal sciences, which actually comes somewhat, hand in hand when you are doing fetal medicine practice, because so many times what is right ethically and medico-legally is extremely important. So we welcome Dr. Ranjit Chaudhary. I'm not able to see him, but I'm sure he's there. Dr. Ranjit Chaudhary. I think we'll have to, pin him up somewhere because I'm not able to see him here, but welcome to the panel. Dr. Viral Pandya is again another, sort of boy to watch out for, because somebody who's gone and trained himself in fetal medicine from a very, very eminent center, the Necker Hospital in Paris. And he learned the language, went all the way there, and has associated himself with extremely reputed centers abroad, as you can see there. These are all like the meccas of fetal medicine all over the world.
Nice to know your credentials, too many.
No, he's
Thank you so much,
extremely,
ma'am.
and
All your blessings.
I've heard him speak once or twice in some of our workshops, and he really comes across with beautiful messages and presentations. So welcome, Dr. Viral. Then we also have Parth Shah, Dr. Parth Shah, who is like a second generation fetal medicine, because he started as a, the son of one of our very eminent colleagues, but I will not introduce him like that here, because he's really made a place for himself, and he's been working in the Rajni Hospital in Ahmedabad, and so many patients, I mean, who have met him, and I see them thereafter because they shift cities. They are really in awe of him and the way he explains things. And he's done a fellowship in endoscopy as well, but he does a lot of fetal medicine work at the Rajni Hospital. He's an invited speaker for many CMEs, and again, we'll hear a lot of good inputs from him. Parth, and I hope that you've realized it's already evening because he must be in the scan room and not knowing where he is. So we also have Dr. Ami, I think. Okay, Dr. Hiten Somani. He's the director of the Nirmal IVF test tube baby and laparoscopy center in Bhavnagar. And he will understand how important it is to manage fetal growth restriction, because especially when it happens to IVF pregnancies, it's really like a, very, very emotional battle for both the parents as well as the IVF consultants. Then Dr. Dhaval Gorasia, also from the fertility background, and he has an international master's in biotechnology and human-assisted reproduction and clinical embryology from Spain. So we have a lot of, people trained abroad and coming back, and then with all the protocols, you have to come back and then again justify all your training and work properly in this country where, like we discussed in the past, every answer has to be individualized for every patient. So he is also an EC member of the ROGS and a joint secretary of ROGS and editor of the ROGS. So we have academic inputs coming in from Dr. Gorasia, welcome here from Rajkot, and Dr. Ami Shah, who I know her as a comrade of Dr. Janak Desai, and she comes with a fellowship in fetal medicine from Ahmedabad, ICOG fellowship gold medalist, and she's worked in Mount Sinai Hospital, Toronto, and is an honorary fetal medicine consultant in the SVP hospital, and is a very good teacher in fetal medicine. So
welcome, Amisha.
Armed with a really nice panel of people from backgrounds varying from pure fetal medicine to a combination of obstetrics and fetal medicine to medical legal and IVF. I think we are very well equipped now to handle this problem of born too small and born too early. So we have IUGR, but at the same time we have preterm IUGR. Varsha madam taught us how to predict and prevent preterm labor, but then she also finished saying that nothing is 100%. You have to, take all the steps, but at some point it's inevitable and the baby has to be born preterm. And then we heard from Dr. Mayank about IUGR and how it can also affect the fetal, outcomes. So here we have a scenario where the 26-week gestation, a primigravida, comes with no significant medical or surgical history, and normal antenatal checkups, first trimester screening, low risk, normal. So we have nothing in the background to actually, consider that there could be some problem. But then at 28 weeks, just a routine growth scan, we see that growth is along 3rd centile, and there is increased resistance in the umbilical artery Doppler. Now, many of you will say, "Arey, pehle kuch bhi nahi tha," lekin nahi tha. and that is it. Nothing was there. And in a healthy primate at 26 weeks, 28 weeks, we see that there is a thing. So what are the important points here to confirm the diagnosis of IUGR? Do we have Dr. Ranjit Chowdhury on? Otherwise, I'll just hand over to, Viral for that matter. What are the important points here that you confirm the diagnosis of IUGR?
Yeah, so first thing, as we had discussed earlier, and I'll repeat that again, sounding the same, that we need to make sure that this is a growth restriction and not a constitutionally small or a small for late stage. So that's the most important thing that we need to see are the previous scans. We need to check how the baby is growing. We need to see if there is a drop in growth or whether the baby was small from the beginning and that's how it is going, that's how it's continuing. That's one thing. And the second thing is one additional point that you mentioned is that there are Doppler changes. So I would like to know how the umbilical Doppler is, how much the resistance is, what's the TI, the centile, and whether there is any forward flow or not, or if there is any absent flow during last year. So these all things would help us determine and diagnose it.
So would you call it early onset IUGR?
Yeah, so early onset and late onset are actually two different kinds of fetal growth restrictions that we have arbitrarily put at a cutoff of 32 weeks. There is no switch as such which falls at 32 weeks. 32 weeks LA early hai, Parmi later. There is substantial overlap sometimes in certain cases. But what we see commonly and usually is that the fetuses which have growth restriction before 32 weeks, they have different challenges, they have a different set of problems and a different pattern of evolution of the disease, while the late onset FGRs behave a little differently as compared to them. So yes, because this is before 32 weeks, you classify it as an early onset FGR.
Thank you, Viral. And I think we don't have Dr. Ranjit here. So Riddhi, I'm going to take the liberty of asking you, is this classification of early and late, which Viral just said, very important? And how would you actually explain to a patient what is early and what is late? Or how you do explain to a colleague why early and late are different?
Ma'am, early and late are different in the form of placental damage. Placental damage is more in case of early FGR. Placental damage is and in case of
if placental damage is more, what do we expect? How does it present clinically?
So, yes, in early FGR, umbilical artery Doppler will show changes because placental damage is 60 to 70%. In case of late FGR, as the damage is 30%, umbilical artery may be normal. So to pick up,
yeah, go on.
So to pick late FGR is difficult compared to early FGR.
Okay, so Dr. Dhaval, do you think it's difficult to pick up late FGR because we are not alert, or you think there is something else that is important? I mean, suppose the biometry is not less than 5th centile.
Yes,
the umbilical Doppler is not showing any changes.
Yes, so
changes.
The classical understanding of FGR may not be exactly true for the late FGRs. The basic understanding is the growth is less, but in late FGR, because the pathophysiology is so subtle, the difference in the weight is not perceptible to call it less than a certain centile. So the diagnosis is many a times missed. Plus, the classical vessel sine qua non for the FGR vessel is the umbilical artery, which may be normal in the late FGR cases. And there is only a subtle diffusion disorder, which is only reflected either in the MCA or it even may not reflect in that sometimes. And still the fetus is having a subtle hypoxia.
Absolutely. So now there are so many changes here. Parth, would you think that there is any change in the maternal condition also, or in the maternal prognosis also, whether it is late or early IUGR?
Madam, in early IUGR, majority cases are the mother might be having some of the other problems. In the late IUGR, it might be sudden onset of the maternal condition, which might be affecting the fetus. Mostly severe preeclampsia, which we are seeing encountered in many of the cases. Or in less than 5% cases, GDM also can cause late FGR in those mothers. So whether normally we are talking about in GDM, we are talking about macrosomia, but less than 5% cases, they might have IUGR also. So all these cases, the mother might be affected. So we have to screen both mother and the fetus. As we have discussed, early and late IUGR are totally different scenario. But here the most difficult one is late IUGR, and they are the one which might trick you or they might dump you in between, because they are the one in which if you are late in diagnosis or if you miss the diagnosis, the family might be in trouble. Even the obstetrician might be taking wrong decision.
So basically, the early IUGR are the ones where the fetus is very severely affected in terms of, the clinical presentation. You are easy to diagnose. The placentas are small, so the Dopplers are also bad. And the mother also may be having some kind of disease like preeclampsia or, chronic maternal disease, where the diagnosis is not a problem. But management is a problem because you are at a gestational age far from term. And in the late IUGR, it is the diagnosis which is the challenge, but the management is fairly, I won't say very simple, but still it's kind of straightforward because you are already crossed 32 weeks gestation. But unfortunately, in our case, we are still at 28 weeks. So she's 28 weeks with a high resistance in the umbilical artery. So Dr. Parth, how would you plan further follow-up from here?
So for that, madam, we can follow the Barcelona classification, or simply because it is early IUGR. Here, the crunch is the venous system is going to help us in making a decision call. So here, rather than CPR, we are more reliable on the ductus flow because we are talking about the early IUGR, less than 28 weeks. So generally, when we see the first thing is affected is umbilical uterine artery, then umbilical artery, and then comes the NCA, which will come down for downwards. The PI will start falling down, and as the umbilical and MCPI crosses over each other, the CPR ratio starts falling less than 1, or we call that, or we can plot it in the graph, less than 5th centile. In between, if the fetal position is good, we can take the aortic isthmus. In generally, madam, in our practice, I am not taking aortic isthmus in all, only in selected cases when it is indicated. And the dilemma,
let's just take just 1 minute. Hold your thought there, Parth. So let's just ask the other specialists here. Are you doing aortic isthmus routinely, Dr. Veeran?
Yes, I am a very big believer of aortic isthmus. The only reason being, if you have a look at the graph on the screen, if you see ductus venosus, it crosses over a little bit to the other side where there is serious injury and death.
Fair enough. No, the question here is just whether you're doing aortic isthmus or not.
Yes.
Dr. Riddhi, are you doing aortic isthmus in all your cases?
No, ma'am.
No. Dr. Ami?
No, ma'am.
Mayank sir, आप भी बताइए, are you also doing aortic isthmus? Your audio seems to have gone again, so you please tell us yes or no, because we have to go on.
We routinely do not perform
anything. So I think Dr. Dhaval, what about you?
Yes, when CPR is altered, I would do aortic isthmus.
Okay, so we have a kind of divided opinion here, but as such, I think I would agree with Parth when he says it's difficult and it's not easy to implement it, especially because the critical role of aortic isthmus comes in the extremely small babies, and it is very technically difficult to do it in those extremely small babies. So more often than not, we check the pulmonary artery as opposed to the ductus. So sorry to disturb you, Parth, carry on from where you were.
So madam, that's how we take the call. And as Viral also said, that he is right that if we rely only on ductus, we might be late. The neurons are already getting damaged. But that's why we are always on guard. We are calling the fetus, the patients early. Might be 3 days, or when the alert sign is very near, when the CPR ratio has already fallen down to less than 1, we are calling the patient very frequently. Or either as an obstetrician, I am keeping the patient in house, check daily. Because मेरा machine है, मेरा patient है, ऊपर से कभी भी बुला के check कर लो, ठीक है? So that's how we can do. So decision making is on the case of ductus here in this patient, fetus 28 weeks.
पहले in utero transfer होता था जहां neonatology unit है, अभी in utero transfer करना है जहां daily Dopplers हो सकता है. That is what you want to say?
No, not I am saying, because I am obstetrician as well as fetal medicine expert. I am having in-house center, so that's why I can do that.
Okay, here let me call in Dr. Hitendra Somani. He is a person from the IVF background.
Somani sir, are you here? Do we have Dr. Hiten Somani online here?
Dhaval is also IVF person, doing a good number of IVF in Rajkot.
Okay, then we'll go to Dr. Dhaval only. So suppose आपका patient है, now you are not the fetal medicine person here. वो उसने आपको फोन किया कि सर ऐसा है, हमारे बेबी को अभी बोल रहे हैं कि डेली डॉपलर करना है, so या डिलीवर करना है. What will be your reaction? I mean, how will you counsel that patient?
See, from an IVF specialist point of view, we go for minimum gestation is 26 weeks. After 26 weeks, we can survive the baby. So the difference is in the morbidity, the cost, number of days of stay. So then it depends. So Doppler will have.
So now in this situation, Parth is saying he doesn't want to deliver. He wants to keep them admitted and just keep checking the Dopplers again and again. Are you going to tell them on the phone कि नहीं भाई अब 26 weeks हो गया, deliver हो जाओ? I think we are having a problem with his net
reducing
connection.
The cost. Yes.
हाँ, नहीं बोलिए sir. हाँ, अभी सुनिए.
We can wait for the yes, ma'am. If CPR is altered, see, we have still not discussed in this case the MCA Doppler. So assuming case CPR is altered, we would do a weekly scan to look for aortic isthmus changes and DV changes. But just before or just when we see aortic isthmus reversal, I would like to deliver this after due steroids and neonatal consultation, of course.
Dr. Ami, everybody is like waiting for some or the other Doppler to get spoiled here. Why is it like that? I mean, the patient comes and asks you, Madam, ये रोज एक नया Doppler का नाम बता रहे हैं. आप बताइए क्या है इसका मतलब importance क्या है? How will you counsel the patient about these Dopplers?
So the main counseling will be that everything needs to be put together, but Doppler plays a very important role in deciding the timing of delivery. Because according to international protocols, they have given the age of delivery according to the Doppler changes that we see. And they have also told us how many times we need to monitor. It is not me who is saying that I need to monitor you so many times. This is the international protocol. So when you follow an international protocol, then you tend to make less mistakes and you can give a good baby. Everybody is trying to give a good baby, but we still need to save our own cells. And we have to follow protocol. So if you follow the protocol, you can see that it has been said that if you have such Doppler changes, you need to do weekly monitoring. If you have such Doppler changes, you need to do it twice a week, and so on and so forth. So that is how I'll explain to the patient.
So when the Doppler changes happen, you put together all the factors together and not look at only one factor, but a combination of the weight of the baby, of the Doppler, of the gestational age. So now she said we have to follow international standards and then give the best to our patients. So suppose the patient says कि ये तो international guideline है, madam, are you sure? आप ये follow करके हमको दे सकते हैं. What exactly do you want to say when you say that international guidelines? There might be an argument anywhere.
Yes.
So does it work for your center? How will you justify that this guideline works for my center? Do you need the help of another person here?
Most of the times we take the help of extreme premature cases. We take the help of a neonatologist because only survival of the baby is not important. Intact survival matters. So if you say that the neonatologist is going to save, say, 80% of the babies, but they should not have those very serious complications of prematurity, the cost, everything needs to be included, and the parents need to understand what they are looking at, and not only the delivery, but the future of the baby as well, both in terms of immediate as well as a long-term follow-up.
Absolutely. So, as perinatology committee chair, we've had this one joint program with Indian Academy of Pediatrics, where we have a common forum where both obstetricians and neonatologists get together. And this is the most important discussion there, that neonatology or the definition of neonatology services varies in our country. So every unit in every part of the country will not have the same level of neonatology services. So some of the centers might be comfortable. Just give me one moment, please. So some units may be comfortable with 28 weeks, even 26 weeks for that matter. But some units may not be comfortable with even 30 weeks. So it's important that you have a neonatologist counsel there, and the other things that you need to optimize the outcome. So Dr. Dhaval, you want to tell us something beyond just the counseling?
So counseling would include the potential treatments, the cost of the treatment, number of days of stay, and nothing is 100%. So we have to put it into numbers. Like a 26-week survival is 80%, 28 weeks is probably 95 to 99%, so something like that. And we also have to give choice to the people. Like if you have 5 centers, you choose your own center. We recommend this or that, XYZ. But because sometimes if survival is not there at certain weeks, then there is also medical legal query. So that's the practical part.
So every center has to counsel based on their capacity. So if you can deliver the baby at that point, deliver. If you cannot and you don't have the facility, then you do an in utero transfer to another center who can deliver. So now this patient Partha had seen, and he said that no problems. Abhi, I will call and scan again and again. So he scanned after 1 week because it was only increased resistance in the Doppler, umbilical Doppler. So after 1 week, the umbilical Doppler is now showing absent end-diastolic flow. So now, Parth, what do you want to do? Deliver or wait? Or do you want to give steroids now?
As we diagnosed early on at 28 weeks, it is IOGR. So as an obstetrician, we have a habit to start steroids. We have
is it a good habit?
Steroid dose. Yeah, it is a good habit. It is a good habit. You diagnose, you give steroids. So that means you don't have to repeat the steroids. First and foremost.
I'll just again, take a vote here. Okay.
Okay.
Because what you are saying is something which is obstetrician friendly, which is sounding common sense friendly. But the thing about steroids is you give a dose, the best effects start after 48 hours of the steroids, but they last only for 1 week. So is it a good habit to just give off the steroid the moment you diagnose IUGR, Dr. Dhaval?
Not exactly diagnosed for, see, ma'am, theoretically.
In this case, would you have given the steroid last week?
Theoretically and ideally, no, but practically, yes, because many times you tell patient to come at a follow-up of 1 week, he may not come at that many weeks.
No, let's wait. Who else is there? Dr. Ami?
I don't practice routine obstetrics, but I would wait because there was just an increased umbilical artery flow, resistance. So I was not expecting such fall. Maybe I would be wrong at that point.
I totally agree with you, but the criticism we will get is you all are theoretical, you don't practice obstetrics, so you don't know. So let's hold on. Let's see some other people under the gun here. So who's the next one? Viral, do you practice obstetrics?
No, again, I don't. So I would not recommend, but I would leave the choice to the obstetrician.
Very good, very nice, safe and sorry. So Ami, what are you doing now? Are you on fetal medicine side? No, not
yes,
Ami. Sorry, Riddhi. Are you on fetal medicine side or obstetrician side? Do you want to give the steroids or wait?
Ma'am, I will give.
You will give when? Now or the last week?
No, if it is increased resistance, I will give. And then again, if it is absent diastolic flow, but still gestational age is less than 34 weeks, so we can repeat it. Rescue course.
No. So let's have some sanctity here. The point about giving steroids is that the best effect of antenatal corticosteroids starts about 48 hours after the full dose of the steroids, and it lasts for 1 week. So in a condition where you are calling the patient for a scan after 1 week, you're obviously expecting that at 1 week, you will still be having an antenatal patient.
Yes, ma'am. There should be 14 days distance. If it is within 7 days, I will not repeat.
No. I'm not talking about rescue steroids per se, but the need, because steroids have been, even 1 dose of steroids have been shown to have impact on fetuses, whether that is needed or not needed in near-term fetuses. There's a lot of study about it. So I think we need to be a bit careful about the use of steroids. So again, this is the place where I would take a neonatologist's opinion and wait in the first case, like when there was positive diastolic flow. When there is absent diastolic flow, we are calling the patient. When we go back to that slide which we saw, when you have absent diastolic flow, you are calling the patient back in almost a day or 2 days because you want to see it so frequently. And that is the time when you may have to deliver if it gets worse in 2 days, and then you won't have time for steroids. But if it is a weekly monitoring, then I think we need to hold on that steroids. It's, it's okay to be safe, it's okay to be practical, but when we are in a forum where we are giving a message to all our audience here, and also citing that we have to follow guidelines, the guidelines do not recommend giving off the steroid unless you are anticipating delivery within the next 1 week. So if there is any steroid related issue like maternal hyperglycemia or anything, nothing will come to our rescue that what was the hurry in giving the steroid. Having said that, I agree, sometimes obstetricians are extremely panicked with some situations, and you have a consultant-led decision. I mean, that leeway of doing a consultant-led decision whenever you are in trouble. So every unit can do what suits them best for that particular case. But if you look at the guideline does not support antenatal corticosteroids. Now, which antenatal corticosteroid is the best here? Who is the obstetrician here? Partha? And Dr. Dhaval, huh? Partha, you need to unmute yourself.
Both metronidazole and dexamethasone both are good if you use the right salt. Metronidazole gives a little bit advantage. The patient, it is twice, 24 hours apart. Whereas dexamethasone 12 hourly, so अगर patient आया 6 बजे आज शाम को, तो कल सुबह 6 बजे आना पड़ेगा. तो वो थोड़ा difficult हो रहा है. So that's why for practical purpose we are giving metronidazole.
Yes.
Yeah, that's again another debate for another day, because suddenly the neonatologists have realized that that is not the salt which is needed. And the problem in India is the salt which is correct is available in dose which is not correct. The dose which is correct is available in salt which is not correct. So the betamethasone salt that we have is not the same as in which international studies were done. And we'll never get that salt because that salt is not heat stable. And the dexamethasone that we have does not come in the same strength. We don't have a 6 milligram dexamethasone dose. We have an 8 milligram, of which we have to discard 2 milligram if we have to use that. So that's another story. So now you want to follow the thing. So the protocol says wait till the ductus venosus is abnormal, as Partha was saying earlier. So even if it is absent end diastolic flow, I'm assuming that none of you are going to consider delivering this baby. So do any of our esteemed panelists want to tell us about the truffle trial? I mean, what was this whole ruffle about the truffle? Dr. Dhaval, anyone? Like, we always keep quoting these trials.
Yes. So truffle trial basically wanted to show that in altered CPR patients, FGR patients with altered CPR, when they are
to deliver either on the basis of Dopplers or on the basis of CTG changes in, I think his connection is breaking. Viral, do you want to step in here?
Unmute yourself.
Dr. Dhaval, your connection. Dr. Dhaval, your connection is a little unstable. So while you correct it, I'm just going to direct it to Dr. Viral.
Unmute yourself, Viral.
Unmute.
Yes.
Dr. Viral, can you unmute yourself, please?
Yeah. So basically, the truffle randomized the patients into 3 groups, and what they wanted to study was it the BV changes that gave a better outcome and could be used as a safety net, or was it the CTG changes, the baseline the baseline variations in CTG, which would predict a better outcome and give us a better cutoff to actually give a better outcome to the baby.
They did ask that we need to kind of look at all the factors together and use the safety net. to have a better outcome. Don't stick to just one criteria for following up the preterm babies. So we've already done the steroid bit. Dr. Dhaval, you can go on. Okay, Dr. Ami, sorry, this question was for you, for the role of magnesium sulfate in neuroprotection.
Yeah, so I don't think this is a very debatable topic. Everybody knows that magnesium sulfate definitely reduces the risk as well as the severity of cerebral palsy in the small, especially less than 32 weeks. And so we need to give it, especially if you know that the delivery is going to happen either in a few hours or even in a few days. And you have to give a bolus
Few
dose.
days, would you wait for a
Sorry,
few
no,
days?
no, to 24, no, for 24 hours, for a day or so.
So
Max.
it's a minimum of 4 hours
4
that the
hours,
magnesium
yes.
sulfate should be
Yes.
on flow, and a
Yes.
maximum of 24 because
24
it
hours,
also
yes.
has a toxicity to the mother.
Yes, mother,
So we
yes.
don't want to start it before
No.
24
Yes,
hours.
ma'am.
Yeah.
Yes, ma'am. So the dose is already known, 4-gram bolus IV dose.
So it's
and it
almost
has to
for
be-
all obstetricians who are
Yes.
watching, it will be
Yes.
similar to the
Similar.
whatever we
PA,
do in
yes.
the
Eclampsia.
Eclampsia
eclampsia
regimen.
protocol.
Yes.
So
and
4
same
grams
on-
IV and
Yes.
1 gram per hour as a
Yes.
standard. Thank
Yes,
you.
and with the same maternal monitoring.
Excellent. So, so here what happens is we have a 28-weeker who had increased resistance in umbilical artery. We didn't want to deliver at that time, but we were not united in our decision of whether we should give the steroid at that time or not. So that means this patient can go to 2-3 different obstetricians and get 2-3 different opinions. And these are the places where you have problems with your medical legal team, where I wish our medical legal expert was here who could have told us, because it's not right or it's not wrong. You know, somebody wanting to give the steroid, somebody not wanting to give the steroid, both have their justifications. So for me, the only way to prevent medical legal problems is to talk to the patient. Every patient should know that you are making an effort to give them the best outcome. These are your pros, these are your cons, these are your, the uncertainty. Suddenly you may come with an abruption and I may not be having time at that time to give a steroid. Suppose you're so driven to give the steroid. You can explain your reasons of being worried for that patient. Because these are the women who also have preeclampsia in the background. These are the women who also have other problems because this is early onset IUGR. So if you talk to your patient and both you and your patient are on the same point. So communication, documentation, documentation of communication, and communication of documentation. I mean, that's what's going to stop us from having medical legal issues. So in that particular case, we would continue to follow her till there are DV abnormalities, and then perhaps take a decision of a preterm delivery in an FGR fetus. With that, I hand over the next case to Dr. Riddhi, who's going to take us through the problems. Riddhi, all yours.
Yes, ma'am. G2P1L1 at 28 weeks of gestation presented with preeclampsia. Previous obstetric history, LSCS was done in view of preeclampsia at 37 weeks. In this pregnancy, normal ANC checkups till 28 weeks. First trimester screening low risk and normal TIFA scan findings. Now at 28 weeks on growth scan, growth is along the third centile along with normal Doppler.
So here you have growth restriction, but Dopplers are normal and the mother has preeclampsia. Great. So Riddhi, where are you?
Yes, ma'am. So
Carry on.
So Dr. Viral sir, how would you approach this case differently as compared to the previous one?
So I would just request you to go back to the previous slide. One thing I want to confirm is you mentioned that the first trimester screening is low risk. So I believe this is for aneuploidy, or does this include preeclampsia screening as well?
It includes preeclampsia.
Includes preeclampsia screening.
So usually what we see is if there is a previous history of preeclampsia in a previous pregnancy in our ethnic group, we tend to fall in a higher risk category. Because we have a lot of obstetricians listening to us, one point that I would like to take before further discussing this case is about the aspirin prophylaxis that should have been started or would have been started before 16 weeks in a dose of 150 milligrams. That would probably help.
So would you start aspirin in any woman who has a previous history of preeclampsia? Or are you considering using that as part of the history parameter? Because there are three things that you look at, isn't it?
Yes.
Biophysical,
It
biochemical,
depends.
and historical.
So
only
it
if the
depends on
algorithm...
the kind of resources that we have, because we have obstetricians who will be practicing in cities as well as in periphery. The best and the most suitable way according to the guidelines is to assess the maternal risk based on history, maternal blood pressure, the mean arterial pressure, and uterine artery TI, plus or minus the biochemical markers, that is PSGF or PAPE. If any of these are not available, at least based on the maternal history, aspirin is as such a very safe drug to use.
Again,
I'm
hold
sitting in
that
a
thought,
village,
because I'm just thinking, one is we are digressing from the main topic of preterm IUGR right now. But since you've raised the issue, very valid point. But I would still stick to the fact that do a first trimester screening properly. Just having a history of preeclampsia, because again, Dr. Viral, while it is okay that our country is resource limited and all these problems, our histories of preeclampsia are also not very clear. There are women who say, "Hum us din gaye, hamara BP high aaya aur section ho gaya." Now, was that preeclampsia? Was that just something else that was going on at that time? And was it preeclampsia related decision for delivery, or an hypertension created because of white coat hypertension decision for delivery? So it's a little this thing. So when we have a confirmed definition-based diagnosis of preeclampsia, and that goes into the history, and then we do the first trimester screening, then only we are justified in starting that low-dose aspirin. As you rightly said, it's low cost, it is a good intervention, but still, in this forum, we are not telling people that you can just start aspirin without a complete, a sort of workup, because rarely, very rarely, but aspirin can cause upper GI bleeds. And sometimes it can be dangerous for the mother. They can have other kind of spottings, epistaxis and things like that. So that's just a word of caution. But I agree with your point that this first trimester screening, whatever we are saying here, should have been critically done for the preeclampsia. But suppose she was low risk.
Yeah. And coming to the question now, my approach would be different, because my first priority would be the maternal high blood pressure. First of all, the high blood pressure needs to be something that has to be addressed, and then we can move on to the growth restriction follow-up surveillance. Once the mother is stabilized, then we can do a follow-up according to the protocol, and we can monitor for doctor changes and all those things that come along with the growth restriction.
So, Riddhi, do you want to tell us why you had this case in mind for a preterm FGR as opposed to the first case? What were the different messages that you wanted to give us?
That in this case, we need to manage maternal condition also. And even if the Dopplers are normal, but growth also matters. If it is third centile, we have to put this fetus under surveillance.
So Dr. Ranjit is anyway not here. So you only go on and explain that in the last time, I only told you that, oh, I don't want to give the steroid while the Dopplers are still normal. But here I want to give the steroids. Am I wrong, or am I confused, or what is my problem?
I would agree and I would recommend. The only reason being that, again, we need to manage the pregnancy as a whole and not just the fetus. So the high maternal blood pressure can lead to eclampsia, can lead to abruption, can create any sort of an obstetric emergency which might require an imminent delivery. And in that case, steroid prophylaxis is always going to help.
So all of us are on the same platform here. No controversies that if the mother is having a medical issue and which might necessitate a delivery, then steroids cannot be withheld because of the fetal condition. So even if there's no fetal indication, we may have to give steroids in this situation. So that's how we confuse people, all the people who wrote last time that we don't give steroids if it is absent. Now we are giving the steroids. Riddhi?
Dr. Parth, sir, can you please summarize the important messages about the dilemmas in managing preterm IUGR with maternal comorbidity?
So, regarding the particular case, right?
Yes, sir.
So, in preterm IUGR, the patient wants to control. Basically, we have to monitor the fetus, as you said. It fit as only it was Doppler was normal, but there was only IUGR. The growth central was falling down. We are putting her on a surveillance. Plus, we are going to control her maternal condition. We are going to screen her maternal conditions. Whether we have seen in many of the patients that when she is diagnosed with preeclampsia, she might be having other comorbidity also. So we have to screen for the other comorbidity also. We counsel the patient. Obviously, the steroid is the first drug of we are going to give her steroids and manage according to the Doppler changes, whichever it comes next. Here, I would like to read I just want to highlight you one thing. In last, as Madam has said clearly, that it is patient's choice and counsel them properly that whether betamethasone has to be given or not. Actually, I'm here for my dinner, and at present there is one case at my hospital. 30 weeks, IUGR, diabetic, and recent diagnosed. Today only she has blood pressure. Only finding as a clinician, which I know, she came with spotting PV today morning, and there was a preterm labor. Most important thing, pre-eclampsia, when there is a high blood pressure, do not give tocolytic. I have not given tocolytic, and I have counseled the patient that wait and watch. I am suspecting abruption. The first bout stop itself, I could not find any abruption, but abruption is majority times a clinical diagnosis. Means bleeding PV and tight like a hard rock abdomen is your finding. Just sister called me. She has started labor again, and there is a bleeding PV second bout. So I'm going to take this patient for C-section. This patient has already been diagnosed with diabetes. Fortunately, we anticipated something. Something might happen. At that time, there was no pre-eclampsia. I have given her steroids at that time 1 week before. She is diabetic, so I need to increase the steroid insulin dose at least 15 to 20 times more. So we have to see the case in a different scenario. Okay. So in this case, giving the steroid to this particular patient, I am happy that I have given steroids. Unfortunately, I have not started Maxel from the morning. And I am going to deliver within 1 hour. So that's the.
So you could have you can start immediately, but again, that is a little difficult decision because Maxelf itself will be a kind of tocolysis.
I'm going to deliver within 1 hour. I'm just here for my dinner.
Yeah.
So I made a mistake. I should have started Maxel for the patient, the same patient which I'm going to deliver at my hospital.
Yeah, but then at the same time, you'll have to, I mean, if you had started also, there was a problem of uterine relaxation leading to more bleeding and things like that. So that's what clinical medicine is, not black and white, you know. So what you are doing, you are justifying each and every step. And if you have told the mistakes. Yeah. So once you discuss this with the patients, they will also understand. See, sometimes it's like, वो doctor साहब ने कुछ नहीं किया. अरे उन्होंने इसलिए नहीं कुछ किया because उनको कुछ नहीं करना था. But there were no options. Yes. There are some situations where हम कुछ कर ही नहीं सकते. So suppose we have the same early onset IUGR because we had only 40 minutes. We didn't put such cases. But sometimes we see early onset IUGR at 18 weeks. At 19 weeks, and we have nothing to tell them because what can we do? Because we steroid nahi de sakte, Maxelf nahi de sakte. We know this is going to be an IUD by 26 weeks, and that is it. So that's okay. We wish your patient all the best part. I'm sure she will do well, and the baby will come out, and things will be fine. So the Riddhi, next case.
G5A4 at 34 weeks of gestation presented with SLE, previous obstetric history. She was having 4 early trimester miscarriages. In this pregnancy, normal ANC checkup still 34 weeks. First trimester screening, low risk and normal TFA scan findings. Now at 34 weeks of gestation, she is diagnosed to have IUGR with growth along third centile and altered CPR. So, Ami ma'am, she is 34 weeks with bad obstetric history with SLE. Should we deliver or should we wait?
Now this is a very, very difficult challenge for me because I have a maternal condition, both in the form of having an SLE, in which she is more prone to PIH and its related complications. You have not written them, so I assume that they are not there.
Yes, ma'am.
And she has had a bad obstetric history as well. So we have extremely anxious parents. We have a very anxious obstetrician. And now she's already 34 weeks with an altered CPR, which in cases of late IUGR is like a sort of a red signal to me. But the management of late FGR cases have not very well been defined. So I would take, so it is my individual opinion. It might not be for all the obstetricians. Everybody might panic, give steroids, wait, and then deliver the baby out. But again, if you look back to the sort of Barcelona protocol to deliver, if I do not have maternal complications which are imminent to delivery, SLE is a history. 4 miscarriages are a history. Fine, it makes her a high risk, but the delivery will not be imminent just because of a maternal condition. I would look at this baby at just as a late FGR with altered CPR. So it puts that baby in stage 1. Still, I would monitor this baby with Dopplers. And I would also like to add something else as well. I would like to sort of tell the mother for the kick counts, maybe add a BPP. I'm not a very big fan of it. And to so enhancing my surveillance protocol, because I know that these late FGR babies do not follow the same pattern of deterioration
Let
as
me
early
ask you a
FGR babies.
question.
Yes,
Dr.
ma'am.
Ami, let me just ask you a question.
Yes,
There
ma'am.
are 3 birds sitting on a tree and you
Yes.
shot down 1 bird.
Okay, ma'am.
How many are remaining?
Still 3. 1 is dead. On the
Yeah,
tree
you
there
shot
too.
you shot down 1 bird, the bird fell down after it died.
Yeah. So
How
then
many are
2.
remaining?
2.
Yeah, so if you are just doing that thing on the fetal medicine point of view, your answer will be 2. Dr. Dhaval,
Yes.
how many are remaining?
So what I'm trying to say is, if what do you mean by altered CPR? Because CPR is altered before your umbilical end diastolic flow is 0.
No.
The CPR is less
Not
than 5th
necessarily.
centile.
Not necessarily.
No,
General-
my point here was that whatever it is, there is a change. She's 34 weeks, the growth centile has come, altered CPR, there
Yes.
is a change. There is a change in
Yes.
Dopplers.
Yes.
And Dr. Ami is very consistently explaining us kya hoga, kya nahi hoga in a very, very
No.
thing.
It's
But
that is
Partha,
what we are
this is a
expecting.
patient
No.
who's Gravida 5A4,
Yes.
SLE, 34 weeks. And now you are telling her the baby is also not growing well and there are Doppler changes. Do you think she'll be sitting there listening to you?
No, definitely not.
That's why I asked how many birds remaining, because once you shoot down one off, the other 2 fly away.
Yeah.
Exactly.
This is not, there is an intangible, you know what the Barcelona protocol also fails to tell us is
Definitely. Yes,
that
yes,
there
ma'am.
is
There are no
something.
definite. Yes, ma'am.
Yeah, because here she's a G5A4.
Yes.
She never
Yes.
went past the first trimester. And
Yes.
now she's at 34 weeks, and you've told her that, okay, after 28 weeks, we'll start talking and this, that, and the other. And now suddenly at 34, there is IUGR. So should we deliver or should we wait? So Dr. Ami gave us a very stoic description of why we should just wait, because this patient can come back for a scan to
Yeah.
her after 1 week. Dr. Partha, what will you do? Will you just wait for 1 week, or he will admit in his hospital and keep scanning every day?
Not always. Not always.
Daily Doppler.
Daily Doppler.
Daily
Daily
Doppler.
Doppler. Not weekly,
Dr.
daily.
Dhaval, what will you do? And
week-
Veera, you
weekly-
are on
Weekly,
opposite side.
See, as per the evidence, weekly Doppler is justified. If absent
Weekly.
end diastolic flow is not there, that we need to confirm. If absent end diastolic flow, deliver at 34. Simple.
No absent end diastolic flow. The CPR is, I mean, the umbilical
If you
is
have
still okay.
some end diastolic flow is there, 1 week is reasonable, justified.
So positive diastolic flow, you are not willing. Why are you so happy with positive diastolic flow? What happens in terms of physiology with positive or absent diastolic
So
flow?
still that level of hypoxia to.
So hypoxia and
We have
acidosis
to-
are what we are risking. Once
Yes.
there is absent diastolic flow, the risk of acidosis increases. Whereas in positive diastolic flow, you would expect hypoxia, but not acidosis. So Riddhi, how are you taking your case forward? People are giving you different ideas.
Ma'am, I will put this baby under surveillance because CPR is then 5 centile is not the trigger for delivery. Trigger for delivery is CTG changes. If baby is showing accelerations,
So when will you do CTG? Abhi 34 weeks.
Is 34, not.
At this gestation, I would like to do CTG. If baby is showing acceleration, we can wait. But if baby is not like.
So are you going to admit? Are you going to admit this patient?
No, ma'am. No. OPD basis CTG. If CTG is good, then then it's okay. CPR is altered, so it is saying that we should put this baby under surveillance. It is not the trigger for delivery.
And the surveillance that somebody said was weekly, you were saying?
Once in a week, ma'am.
Once in a week. So is everybody happy to see this patient after 1 week?
Yeah, we can wait.
If parameters are what they are written, assume.
Yes. Viral, you want to say something? Huh?
I would probably differ a little from the cohort here. This is a precious pregnancy.
Oh, now precious pregnancy. Everybody will ask, what about other pregnancies? They are not.
So what I mean to say is my point is that this is first of all a growth restriction at 34 weeks. So it falls into the late onset FGR group that we discussed. And by late onset FGR, what we mean to say is that it may or may not follow the classical pattern of Doppler changes. And because the mother already has a comorbidity and because the CPR is already less than the 5th centile, 34 weeks sounds to be a reasonable age when I would discuss with the neonatologist and offer the patient probably to weigh the risk of a delivery versus continuing and possibly having the baby develop changes at a speed which we might not be able to predict.
So basically, we are not really very sure whether we should deliver. It seems okay because it's 34 weeks. Why not? Because, you know, as an obstetrician, your heart is in your mouth when you're dealing with these cases with G5A4. And you've brought in the neonatologist to help you, which is a very reasonable thing to do. Because, you know, that is where we need help. With SLE, there can be an abruption. With SLE, she can have a sudden onset of preeclampsia. She could have anything at that point, and we need not go back and repent that, oh, we didn't do that earlier. Nobody talked about steroids here. Do we give steroids? Do we not give steroids?
We give steroids, of course. Low threshold.
Everybody agrees? See, why I'm getting everyone to agree is our patient should not get confused because, you know, patient will have all your phone numbers. All of you put up your advertisements on the internet. She Googles Gujarat fetal medicine. She gets everybody. And then she keeps on asking one after the other. Madam, उन्होंने कहा ले लें, आप क्या बोलते हैं? तो आप क्या बोलेंगे?
ले लो.
I think, yeah, we would
We have to
definitely.
give the options. We have to
Yeah.
counsel both sides and we have to give the patient.
Case of SLE.
Madam, here I would like to highlight that she is a case of SLE. The things might worsen very rapidly without our knowledge. So Betnesol is justified here in this case.
So the message that I'm getting from all of you is when it is a purely fetal condition, you are trying to stick to the guidelines and give it when it looks inevitable. But when it is a maternal condition, it might be on the safer side to give it off because maternal conditions are sometimes unpredictable. We don't know how things are going to work. It comes.
Yes, ma'am, perfectly summarized.
Yeah.
Logically speaking, SLE is an inflammatory condition. Why not give steroids? Yes, they will be on steroids, probably.
Yeah, but then that steroid doesn't, I don't know, for unknown reasons, that steroid does not
it may potentially be even be helpful. So that is, you think laterally.
Fine, let's take it as it comes. And of course, if you need to have a rheumatologist opinion there because everybody's SLE is at a different stage of disease at different times. So what is her rheumatological state? I mean, you know, they have these complement levels, they have some antibody level, they have number of things which sometimes we don't remember. And it's good idea to keep that, you know, multidisciplinary setup going on and the rheumatologist stepping in also to give his or her inputs. So we've kind of covered this. Riddhi, you can go with this one.
No.
Yeah,
no,
we'll have to stop.
Yeah.
Yeah,
there
because
is
it's
one
almost
question,
10 o'clock.
Dr. Chinmay, there is
Yes,
one question from Dr. Shikha Malik. If at 32 weeks bilateral uterine artery PI is raised and A5 is 5.5, what to do?
At 32
weeks bilateral uterine artery PI is raised. How much that she has not mentioned and A5 is 5.5, what to do?
I will tell Dr. Shikha that I am not the panelist this time, so the question will be answered by somebody who is in the panel. Because I didn't prepare anything for this.
So, yeah, I know.
What are the fetal
otherwise somebody should write it
the question, no, I'm just joking. The question is a good question, but here it's a 32-weeker with bilateral uterine artery raised and AFI 5.5. Dr. Viral, what are the first thoughts that are coming to your mind? 32-week pregnancy, bilateral uterine artery raised.
First thought is that because only this much information is given, I assume the growth and rest of the doctors are not.
Yeah,
Saying
so Dr.
that,
Shikha, this is the first information that you should be giving us, whether the fetal growth is appropriate and how are the fetal Dopplers. Because here the role of umbilical Doppler will be, uterine Doppler will be corroboratory. If you have fetal growth restriction, then the uterine resistance corroborates that this is uteroplacental insufficiency related. And otherwise, if you have just that increase, baby's growth is fine, Dopplers are fine, and AFI is 5, it could be a purely renal cause of, AFI being less at that time. So the fetus could be having a, lower urinary tract obstruction or something like that. So a decision for delivery.
silent leak as well, probably.
That also. So the decision for fetal management will depend on the condition of the fetus, and Dopplers will only tell us about the hemodynamics of the fetus. So suppose there is a renal abnormality in that baby, the AFI could be related to that. Or if there is a leak, like Dr. Viral said, the AFI could be related to that. So we need to work this up properly and then do. CPR is normal. How about the growth of the baby? What is the estimated fetal weight of the baby? Is it appropriate for gestational age? And when you say AFI, is that the 4-quadrant AFI or is that a single deepest pool? Okay, we are getting, I think she is typing and giving us the information, Dr. Shikha. Thank you for interacting with us. That's making us happy because, on the Zoom-based platforms, we don't know who's listening. So when people actually get back with questions, so 34.5%, there you go. So the growth is perfect. There is no IUGR, and there is only low AFI, which is again 4-quadrant or single deepest pool. Because if it is single deepest pool 5.5, then we are happy. Then it's
I would like to add a point.
Yes,
as per the Barcelona protocol, Grata Post protocol, even isolated uterine artery PI raised is FGR, even if growth is normal. If you see, can we see the slides of the growth?
The understanding, the understanding there. So we have to wind up first. So that's why what I want to tell everybody is when we do growth restriction, dating is most important. Serial monitoring, and if there is a fall in centiles, unless there is a fall in centiles, you cannot have growth restriction with no growth restriction. So either the baby is altogether SGA or it's falling in centiles. And when it's falling in centile, it may manifest as just absent, abdominal circumference being small, or, other parameters as they have said, but it is always a composite thing. The Delphi consensus, if you look at it, there will be 2 or 3 parameters there, which will tell you. So if it is AGA, there has to be a very specific reason to call it growth restriction. I think all the other issues we have several times highlighted, the Dopplers, the steroids, the magnesium sulfate, maternal comorbidity, multiple pregnancy we'll deal with another day. Varsha ma'am, thank you very much for the opportunity.
Thank you
Riddhi,
so
thank
much.
you very much. Dr. Parth, Dr. Ami, Dr. Viral, Dr. Gorasia, all of you. It was really fun, and I think we just passed time without knowing how much time we passed.
Thank you so much, everybody, for this nice high standard discussions about this FGR, and the very subtle and prominent take-home messages also people could get it. There were many questions also. I'm getting on my messages. I will forward it to you, Dr. Chinmay. And I want to thank each and everybody of the panelists who gave their inputs very well updated, well read, and though the young generation, but they are really ready to contribute their knowledge, and I really appreciate that. And I thank you, Dr. Chinmay Ratha, for giving such a very nice panel discussion with new highlight, new views, and great take-home messages also in that. And I would like to thank the Sahitya Priya Shield person for giving the platform. And another thing, I would like to thank the chief guest, the chairpersons, and the guest of honor also for gracing the occasion. Thank you, Riddhi Bhatt, for moderating and helping me out. Thank you so much. Shabba khair.
Thank you.
Dhanyawad. Radhe
Thank
Radhe.
you, Dr. Arsha. Thank you for the opportunity
Yeah,
and all the
thank
best
you.
for your mission.
Thank you so much. Thank you.
Thank you.
Thank you.
Love
Thank you
you
so
all.
much, ma'am.
Thank you,
Thank you. Thank
ma'am.
you for the
Thank
opportunity.
you.
Thank you.
Thank you so much.
Thank
Thank
you.
you.